Hi everyone and welcome. My name is Wendy and I'm a third year medical student. Today's section is talking about how to do a GI assessment. So before we dive into performing the examination, we have to understand the clinical value of it. First, it's about diagnostic reasoning. The physical exam is our primary tool for gathering real-time clinical data. We want to accurately identify what's happening inside the patient via the assessment. Second, it allows for differential refinement. A patient presenting with abdominal pain could have many different issues. The physical exam is how we narrow the list down. By identifying the exact location of the tenderness, the presence of a scar, or the borders of an organ, we can rule out unlikely causes and refine our focus. Finally, it's critical for interprofessional care. When we can clearly present findings to our colleagues, this ensures that the whole team, from the bedside to the operating theater, is working from the same care plan. This examination follows the pattern of inspection, palpation, percussion, and auscultation. Now, let's look at the essential preparation and the initial steps required before the physical examination begins. Step 1. Sanitize. The very first step is infection control. You must wash your hands thoroughly to ensure patient safety. Step 2. Introduction. Introduce yourself clearly to the patient. State your name and your role, and confirm the patient's identity, usually by checking their name and date of birth. Step 3. Consent. Explain exactly what the examination will involve. It's vital to gain the patient's informed consent before you proceed to ensure they are comfortable and willing to be examined. Step 4. Bed area inspection. Before touching the patient, take a look at the environment. Inspect the bed area for clinical rules. Look for things like disposable vomit bowls, feeding tubes, nutritional supplements, or any medical equipment that might give you a hint about their condition. Finally, observe their general appearance. Do they look well or in pain? Note their color. Are they jaundiced or pale? Build, wasting, obesity, discomfort, how they breathe, and the conscious level. So we now start with the hands. The hands can provide significant clues about a patient's internal gastrointestinal health. First, we can look at the color and texture. When we examine the palms, we're looking specifically for palmar erythema, which is a redness of the fleshy parts of the palm. This can be a sign of chronic liver disease due to increased circulating estrogen. We also check the palmar creases. If they appear pale, it's a strong indicator of underlying anemia. Next, assess the temperature of the hands and look for finger clubbing, which is a vital sign that may point toward hepatic cirrhosis, inflammatory bowel diseases, or celiac disease. Then, we inspect the nails for specific nutritional and metabolic indicators. Look for leukonychia, which are white spots or lines on nails. While often caused by minor trauma, total whitening can indicate hypoalbuminemia, often seen in liver failure or malabsorption. Koilonychia, or spoon-shaped nails, which is a classic sign of chronic iron deficiency anemia. Other skin signs including spider nevi. It is a single central arteriole with radiating dilated capillaries. It occurs in 15 to 20% of healthy individuals, but multiple spider nevi suggest underlying liver disease with increased circulating estrogens. 99% occur on the upper trunk, head, neck, and arms. We may also see the Dupuytren's contracture, which is the fibrosis and shortening of the palmar aponeurosis. Asterixis ask the patient to hyperextend their wrists and maintain the position for 15 seconds. A coarse flapping tremor suggests liver failure with failure of ammonia metabolism to urea. However, asterixis can also be seen in renal failure and in respiratory failure with CO2 retention. Next, check the patient's pulse and blood pressure. Moving up from the hands, We now focus our attention on the eyes. Begin by inspecting the sclera for jaundice or yellowing, which is a hallmark sign of liver dysfunction or biliary obstruction. Gently pull down the lower eyelid to check for subconjunctival pallor. A pale appearance here is a strong indicator of anemia, which may be caused by chronic GI blood loss or malabsorption. Look for xanthelasma, which are yellowish deposits of fat that typically appear around the eyelids. This can be an indicator of hyperlipidemia. Examine the periphery of the cornea for a white or grayish ring. And finally, look closely for Kaiser-Fleischer rings. These are the brownish green rings that encircle the iris, caused by copper deposition in Wilson's disease. We can also look at the face for any swelling or change in color. Now, let's move to the oral cavity. First, inspect the lips and oral mucosa for telangiectasia, which are the small and dilated blood vessels. Also, look for pigmentation around the mouth, which is often associated with small bowel hematomas. Check for angular stomatitis, which presents as sore, inflamed corners of the mouth. This is frequently caused by a deficiency in iron, vitamin B12, B6, or folate. Examine the tongue for glossitis, an abnormally smooth and red appearance. It is important to note that if it's painful, which suggests a B12 or folate deficiency, whereas painless glossitis is more typical of iron deficiency. Assess the moisture of the mucous membranes for signs of dehydration. Note any halitosis, which can be a sign of poor oral hygiene or underlying systemic issues. Finally, look for dental caries and oral ulcers. Next, we examine the chest wall and the cervical lymph nodes for signs of chronic liver disease and potential malignancy. Inspect the chest for spider nevi. Check for gynecomastia, which is the development of breast tissue in males. In a GI context, this is often a result of increased circulating estrogens due to liver failure. Now, move to the neck to palpate the lymph nodes. Pay close attention to the left supraclavicular fossa for the troisius sign. This refers to an enlarged left supraclavicular lymph node, also known as the Virchow's node. Finding this is a significant clinical marker, as it strongly suggests a metastasis from an underlying intra-abdominal malignancy. We have completed our systemic top-to-toe inspection for peripheral signs. We are now ready to focus directly on the abdomen itself. Before the patient lies down, ask them to sit forward briefly. This allows you to inspect the skin of their posterior abdominal wall for any scars, swellings, or other clinical findings that might be missed from the front. After that, you can ask the patient to lie flat on the examination couch, with their arms resting naturally by their sides. As we inspect the anterior abdominal wall, one of the most important things we look for are the surgical scars. These are the clues that tell us about the patient's past medical history, even before they speak. So it can be a midline incision, which is a large vertical scar used for emergency laparotomy or major bowel resections. Or it can be a perimedian incision. It is also vertical and parallel to the midline, but it's now largely replaced by the midline approach because of its complexity and poor cosmesis. A surgical scar can also be a gridiron or a lens incision. They're both located in the right iliac fossa, while lens is more horizontal and bikini line friendly. They are both used for appendectomy. Phalansteal incision, it's a transverse suprapubic scar, which is standard for obs and gynae procedures, say for example, C-section, radical open prostatectomy or cystectomy. Coca incisions, which is a right subcostal scar. and it's typical for open cholecystectomy. If the abdomen appears enlarged, we use 5 F's to categorize the potential causes of abdominal distension. So the first F is fluid. This refers to ascites, which is an accumulation of fluid in the peritoneal cavity, often seen in liver cirrhosis or heart failure. Feces, which means you're gonna have a severe constipation. Flatus, this is seen in cases of subacute intestinal obstruction where the gas builds up in the bowel loops. Fetus, in any person of childbearing age, pregnancy must be considered as a physiological cause for a distended abdomen. Fat means obesity. And further inspection points are scars, because sudden weight loss will result in loose folds of the skin, while sudden weight gain can cause stretch marks. Also shape, symmetry, visible peristalsis, masses, or swellings.